At a major infectious disease conference in Washington, D.C. in October of 2019, Nick Van Hise and colleagues presented really intriguing data with regards to the usage of vancomycin as prophylaxis to prevent C. difficile infection. This topic is somewhat controversial based upon a study from the early 1990s when Stuart Johnson gave a group of individuals who were carriers with C. difficile, meaning they had it in their system but they didn't have the active infection, either placebo or vancomycin. He then followed them for 3 months and checked their stool studies 3 months later and showed that the group that received vancomycin had a positive stool test for C. difficile at a rate of 67%, whereas the group that received placebo had a positive stool assay at a rate of 11%. Therefore, the group that received vancomycin were much more likely to have the C. difficile remain within their system. It was believed at that time that this was a result of the vancomycin altering the microbiota in such a way that the microbiota was weakened and unable to wipe out the C. difficile and get rid of it from the system, whereas the group that received a placebo did not have that alteration to their microbiota, and therefore they were able to fight off C. difficile and eradicate it with a much higher frequency. As a result of that study, for many years it's been disputed whether or not giving vancomycin as prophylaxis might be helpful to prevent C. difficile. Nick Van Hise and colleagues took this topic head on in this abstract presentation. Within their study design, they devised a scoring system for the risk of C. difficile. They applied this risk scoring system to a 400-bed hospital in Chicago, Illinois. The scoring system included risk factors for the infection, including age over 65, age over 80, system-wide antimicrobials, a history of C. difficile within 1 year, a history of C. difficile greater than a year in the past, the length of stay from the hospital, any recent hospitalization, acid suppressive therapy, among other potential risk factors. They then applied that scoring system to a group of patients historically in the year 2017. If an individual had greater than 13 points through the scoring system, they were thought to be high risk. In 2017, that high-risk group had a rate of 88% getting C. difficile subsequent to admission to the hospital. In 2018, they applied that scoring system to patients that were hospitalized. Overall, they found that there was a significant reduction in the rate of acquisition of C. difficile when vancomycin 125 milligrams orally, given twice daily, was administered to the patient cohort at greatest risk, those with a score greater than 13. They found a reduction to 8%. So historically, the group that had a score of 13 or above got C. difficile 88% of the time, whereas the group that received suppressive vancomycin 125 milligrams twice daily, they got C. difficile 8% of the time. That significant reduction was really remarkable and argues in favor of prophylactic vancomycin in a high-risk patient group. Within my practice, in patients that have had multiply recurrent C. difficile, I typically will give prophylactic vancomycin 125 milligrams twice daily for the duration of another antimicrobial if they require another antimicrobial for a system-wide infection. But this abstract really stirred the pot and created much more convincing evidence that prophylaxis with vancomycin might be a very effective therapy.